nicely. So we're lucky to have Dr. Ganesh Vigneswaran, who is an NIHR clinical lecturer in interventional radiology at the University of Southampton. Ganesh really is one of the rising stars in the academic IR space, having recently won a very prestigious prize at the International Global Embolization Symposiums and Technologies Conference. Welcome, Ganesh, and really look forward to your talk.
Hi there. Thank you very much for inviting me today. I'll just bring up my slides. Can you see my slides?
Yeah, I can, yeah.
Brilliant. Thank you very much for that very kind introduction. I'm just basically going to talk really about my research journey, how I got into doing research, how I'm balancing that with my IR time. And then I'm going to talk about machine learning, because I think that's really, the next big thing really. And we need to keep up with machine learning and AI if we're going to compete, certainly with the rest of the world. So let's start. So why should you get involved in research? Well, there's several reasons, really. I'm sure Tom's already gone through many of these already, but number one, CV. Having been involved in research means that you get to put stuff down on your CV, whether that be presentations, prizes, publications, collaborations, grants. So many reasons as why you should be doing research. That can obviously lead to you getting a job. That might be useful for, if you want to work in a specific area. But ultimately, it's all about the patient. We need to make sure that we're keeping up to date, changing medical practice for the better using research. And I think really the new frontiers in research are actually to now look back at the data that we've already got. We've got so much data, radiology data, clinical pathological variables. We can use that to work out what to do next. Because as I'll go on to later, clinical trials cost a lot of money and are often based on hypotheses that are testable but have limited evidence. Whereas we've already got all of this data and we should really use it. But I know that you're going to tell me that there are loads of barriers to research. And it's funny because Tom, your slide on curveballs, I mean, I've been hit in the face by every single one of those along the way. And I probably still am facing that. And I've told you time and again, I'm guessing. Number one, not enough time. It's really busy, isn't it, to do radiology and then to do research on top of it when you're so tired, if you've been in the IR suite, it really can take it out of you. And I understand that. Can't find a supervisor. I think that's probably the most critical reason as to why people don't do research, because you just don't know who's doing it in consultant posts, in senior colleagues, to actually guide you to do the right things. Not familiar with stats, again, very common excuse. And I think, again, that is a real problem. But as Tom alluded to, I mean, getting familiar with stats will raise your game massively. Not good at writing and not familiar with procedural ethics. I mean, I'll tell you how I went into research, and I'm not familiar when I started doing my clinical lecture post in terms of procedure, in terms of health-related research and ethical approval. There's a lot of red tape, but actually it's just form filling. Yes, it does take time, but there are other people out there that can help you. So should I do research? Well, interestingly, publication in ClinRad by people in Portsmouth, I think in part Radiant Group, showed that 73% of trainees would like to be involved in research. And it's part of the RCR core curriculum. You actually should be doing research. So we should be doing research and we want to do research, but actually not much research is happening. My example, so I went to Imperial and did a BSc in anatomy and neuroscience. It's funny because I always wanted to be a surgeon, and they didn't have anatomy at Imperial for a BSc. So I transferred to UCL to make sure I could learn my anatomy and neuroscience. And when I got there, I didn't know about the procedure, and all the other students had research projects, and we had to get this project that we would do for the whole year. You should have contacted your supervisor, 2-3 months before, and I didn't have any. So I had a massive panic. I pretty much emailed every single supervisor on the list, maybe like 50 emails. All of them basically said, no, we've already got a student. But there was one spot at Queen Square, and they wanted someone who was good with computers. And I thought, well, I can use computers. I spent a bit of my time in A-levels kind of playing with programming, design a few kind of basic computer games. And I was like, well, I can do that. Got to the interview. I was like, yep, I can do this. And they were like, you'll have to learn how to use Matlab, which is this statistical kind of mathematical software. I was like, yeah, I can learn that. That's fine. And then I started, and it was just awful. It was really difficult. It was a completely different language. My supervisor was excellent, but he himself didn't program. But the postdoc was a Russian mathematician / computer scientist, and we had a biologist, and they used to get very angry at me when I didn't understand how to program. But just before I was about to burn my laptop, I actually understood how to program. It just kind of clicked one day, and that led to me doing a PhD. So I applied with my professor for a studentship, essentially, to get a salary for 3 years. And this is kind of the summary of what I did. So I recorded from macaque monkeys whilst they were grasping different tasks, and essentially discovered a thing called a suppression mirror neuron. So here I show on the left. So these are neurons that are active when the monkey grasps an object, but they also are active when they watch a human grasp an object. And the key point is that we want to use these type of signals for brain-machine interfaces, so that for quadriplegic patients to control robotic arms. But the problem is that if you've got a neuron that's active during execution and observation, then the question is how does the monkey not move when he observes somebody else lift an object? And the reason is that I discovered this thing called a suppression mirror neuron that decreases its activity below baseline, and it kind of cancels out the effects in the cortex. And the hope is to then use that for brain-machine interface. So I really learned how to do a powerful kind of statistical analysis and management of big data from that project. And that has just set me in a great position for bringing transferable research skills to the clinical health setting. And there was that initial learning curve, but now, persistence pays off. And I think that's the important point. I think it will always be hard to learn the stats at the beginning and to use SPSS or Matlab or whatever. But if you keep persisting, one day it will click, and then you can do it for everything. So then I did an AFP in London, and then I thought to myself, I'm going to just now focus on clinical. And I completely switched, because I was like, before it was like neurosurgery, then I was like, right, I'm going to do neurointervention. That's way more cool. And you get better working hours. And I started my radiology training and started going to the NIHR suite, and found it really boring. No one was doing research. Everyone was doing service provision. And then I met Drew McLean, who's now a consultant at Southampton. He was a senior registrar at the time, and he said, oh, look, I've got a project on IR. Would you like to be interested? And it was the UK ROPE database with PAE. And from there, basically, I just started doing a number of research projects, and really caught the bug for doing IR and research. And finally, I was approached by Prof. Mirazami, one of the surgeons at Southampton, and Sachin Modi, one of the consultants, to consider doing a clinical lecturer post, essentially, to dedicate my time, because I was finding myself, hitting those curveballs. I was up at 3 a.m. on a Saturday morning writing a paper or doing analysis, and I was just burning out. And this was just basically the perfect opportunity to do so. And so I started that job in March of this year. So how's my time split? So 50% academic, 50% IR. It's quite a difference, isn't it? Really going from 100% those 8 or 9 IR sessions to basically 5. And then you've got to remember that within your IR split, you've got to find time to do reporting. You've got to find time to learn how to do MDT. So I had a discussion with my supervisor, and I thought, whilst I could CCT at the same time, it's negotiable up to 4 years. So I said, well, I'm going to take the full 4 years to make sure I get enough procedures. And I think that balancing that act between academic and IR is really, really important. And I'm in no rush, and I'm really enjoying it. So what kind of stuff have I been doing? So like I said, I worked on the UK rope database, looking at the technical outcomes. You've got multiple variables within that database, and trying to make sense of it in terms of the output, in terms of prostate volume size, IPSS reduction. And I use principal component analysis to basically find what was working well. And we found that small spherical embolics were kind of the best for outcomes. I looked at how storage and voiding symptoms in PAE can be differentially affected compared with surgery, which might give us an idea of the patient selection that we want. Recently looked at coiling of penile anastomoses in patients who've got large collaterals. I've seen on Twitter a couple of times people worrying about these large collaterals and whether they should coil them or not. And if they coil them, do they cause any erectile function? Well, we've shown now that it does not cause, and in fact, you can get an even better response to the prostate. And I've worked on some fibroid work in terms of resorbable embolics, and we've shown also that there's no impact on fertility regarding anti-Mullerian hormone. The point I'm trying to make is that by getting involved in research projects, I just started with one with Drew, and new paths were opened. The majority of that work was done alongside my normal day job before I got the post. So now let's go into machine learning. So we live in a world with a wealth of data, and as radiologists, we have access. We're the gatekeepers to these complex data sets. All the surgeons, they know what they've got their clinico-pathological variables, they've got histology data. But when it comes to imaging, we are the gatekeepers. And the key is to use our resources to expand knowledge. So using imaging, a picture paints 1,000 words, right? So there are lots of hidden variables within that image. If we can use imaging to select patients that we should be treating, or find out predictors for survival or predictors for outcome, then we're going to be making, doing a really good service, because it doesn't cost that much money. We've got the data already, but clinical trials, they do cost a lot of money. They are, millions of pounds. So what is machine learning and deep learning? So deep learning is a machine learning technique. And basically what you're doing is you're teaching the computer to do what you do naturally, and that is to learn to recognize what things are. And you train the data on a certain number of images and say that, and correlate it with the output variable. And then you test it on some new data. So here's an example I've got here. So we've got a picture of a flower. You can use almost like a sliding window going across each pixel, and you're looking out for different light or dark shades. Those shades can then be activating a different layer within this neural network that will then pick up a complex shape. From that complex shape, you can then see a probability distribution that will say, is this a flower? Is this a cup? Is this a car? Or is this a tree, for example? But what you can do is that not just use this to say this is a flower or not. You could say this picture is associated with a bad outcome, or this and a different picture is associated with a good outcome, and then see if you can then go back to the original image to show, all right, yeah, this is these patients are going to do badly in this particular therapy. So what's machine learning compared with deep learning? So deep learning will use the whole image in this convolutional neural network. And then as you've got an example over here, and it learns that this is a car, it learns how to feature extract rather than calling it a truck or a bicycle. Whereas machine learning is you can manually extract the feature, which makes it a little bit quicker to then classify this as a car, truck, or bicycle. But we can also exploit different ways of deep learning. So you can either train your data from scratch. That means have your original CT scans, for example, and train them and say, this is this scan is equal to this output. Or you can do something called transfer learning and feature extraction. And transfer learning, I'm going to go into now, is a really exciting field. And it is really useful in where you've got limited data. So at the moment, I said that we've got a lot of data out there, but it's very heterogeneous, and you need to be able to work on small data sets first to then extrapolate on the larger ones. So the current projects I'm doing with machine learning. So I've started off by looking at esophageal cancer and working with Professor Tim Underwood in integrating radiology data with his histology data to predict response to chemotherapy prior to surgery, because many of the patients relapse. And so what we do is we use a pre-trained neural network called Exception V1. And these are images taken from Exception V1 here on the right, made from more than 14 million images. And it's doing exactly what I showed it on the previous slide. It's able to take out the shapes, the features, and to classify these objects. Well, instead of saying there's 14 million objects, you say, this is a chemotherapy responder. This is not a chemotherapy responder. You use the same feature extraction, essentially. You convert each image into a large vector. So with the histology, which has been done now already, you can split each of these parts of the slide into different areas, extract those features, which are 2048 variables, and then do testing and training to work out whether you can predict or not. And that gives you an AUC and a ROC curve. I've now started my own project, and I've submitted a grant for looking at DELCATH or melphalan therapy in ocular melanoma to predict patients that are going to benefit from the therapy, because it's very costly. We've looked at our data along with Tom Sheehan on the survival of these patients. And this is just a Kaplan-Meier curve on the left showing the survival and showing that melphalan therapy is very useful. But as you can see on the right, when you split that in terms of complete response, partial response, stable disease, and progressive disease, there's a large proportion of patients that have a much poorer survival. And if you can predict who these patients are compared to the complete responders, then you know who to treat and who to potentially offer alternative therapies. And the way that we're going to do that is by taking the pre-procedural CT, creating a tumor mask, and then extracting the features via a pre-trained neural network such as ResNet, integrating the clinical pathological variables, and then classifying each of those patients as a responder or a non-responder to predict tumor response and accuracy. I'm also looking at sarcopenia in collaboration with Claire Bent-Bournemouth, looking at colorectal cancer and morbidity to see whether patients with low body mass are staying in hospital longer, because if you can predict those patients, then you can start thinking about preparing them better for surgery prior. And also looking at an adrenal AI project with Portsmouth to try and segment adrenal lesions as malignant or benign on a single phase. So I'm just going to finish with some tips and advice. So I think this has already really been covered, but I really am echoing what's been said before, but make a plan, but be flexible. My plans have changed completely from when I had started out. I think by planning, you just set yourself, at least for the short-term future, okay, I want to get this particular job, so I'm going to need to do this project to get a publication. So just a short-term goal. That might then lead to you doing more projects and then go with the flow. Start with a retrospective study and see if you can look at outcomes, make sure they're measurable as well. Sometimes you'll be approached by people with projects there and you don't have a measurable outcome. You're basically going to go down a rabbit hole and waste time. So it's really important to look at what is the outcome variable. If you need ethical approval or data sharing agreements now these days, if you're going to start doing machine learning, you need to be involved in the logistics of that process. How do you do that? You find people who can help. I really recommend going to conferences in person if possible, presenting your work as opposed to an oral presentation, because you get ideas, you get more ideas about how to present your work, whether your work will be acceptable, and also, you can predict what the reviewers are going to say. Additionally, you will be able to find people to collaborate with. So, top tips: find seniors that are involved in research. I found Drew McLean, which is amazing. You need to find someone like that. A good supervisor is key, because if you don't know what you're doing, you don't have any guidance, you're just going to be wasting time. Can you get software from your training scheme or library to do basic stats? I know that the University of Southampton offers SPSS. Going on the courses, useful, yes. Start small and supervised and then plan on the bigger projects. You don't have to go for the massive projects to start with. Just literally take a retrospective study, work on that, get some outcome data for it, and then you can buy a bigger chunk. And always, if you can't do it by yourself, there's someone else who can. Collaborate. So thank you very much. Just want to thank my past and present supervisor, Prof. Roger Lemon, Alexander Kraskov, Dr. Sachin Modi, Prof. Tim Underwood, Prof. John Primrose, and Drew McLean. Thank you. Any questions?
Thanks, Ganesh. That's brilliant and really exciting to see how you're able to analyze the UK rope studies. I mean, it just shows how unique your skill set is. And I don't know if there are any questions in the chat, but I had a quick question on, well, how did you find your learning curve with the sorts of machine learning techniques that you applied on the UK rope data set? Obviously, you've got a programming background, but someone who wants to learn those skills now as a student or a junior, what would be your advice to them, how they could start?
So, yeah, that's a really good point. I basically did a lot of self-learning. There are a lot of packages available on Matlab, for example, that you can use to learn how to do machine learning. But I would recommend, if you've never done it before, going on courses. I know that I've seen a number of courses offered by different universities where they're teaching machine learning because they know that this is what's desirable now in healthcare. If you look at RSNA, half the stuff is on AI now. I think RSNA itself has its own course as well that you can potentially sign up to, and collaborate. So you are not going to be the expert. I'm not an expert in machine learning. I know how to do it. I know the gist of it. I know how to apply it. But there are people in your universities, in your hospitals that do know how to do it. And so I've collaborated with computer sciences department at Southampton, and they're incredible. You let them do that bit. You just need to know how to apply the health data to it, because they don't understand that aspect of it. They don't know the limitations of their data. We as radiologists and academic radiologists, we need to learn the limitations of what we're giving them. If you input and out, if you give bad input, you're going to get bad output. So we need to give them the right data. So, what I'm saying is collaborate with people who know how to do it. Get on courses to learn how to do it, to at least understand it, and make you are valuable even if you can't do machine learning, yourself.
Ganesh, can I ask for some other people who probably want to know as well? How do you go about reaching out to these departments in universities associated to the hospital, and is it just strictly through your lectureship role, or would you be able to do
that's
that?
That's definitely helped, but you'll be surprised how much they are really wanting to do this. They're actually, a lot of them are really bored with what they've been doing now on cars, driverless cars. I mean, one of the professors was saying he's just sick of doing driverless car stuff. This is a challenge for them. This is a real challenge because it's such heterogeneous data, and it's piecemeal sometimes. You know, all our patients have had previously different treatments, etc. I literally just emailed them saying, look, I'm interested in doing this particular project. Would you be interested? And set up a Teams meeting, and they were all over it. So each hospital usually has if it's a tertiary hospital, will have a university associated with it, and I think should find out whether they have a computer sciences department and collaborate.
Brilliant. We've got a question from Michael and comment. I completely agree with Ganesh. I don't think it's our aim to be the best machine learning practitioner. The unique selling point for us clinicians is the clinical question and understanding of the data. So a comment from Michael. Thanks, Michael.
Completely agree with that.
Any other questions at all?
Yeah, so Ganesh, from your understanding, are there any any outcomes that have been generated from this type of research already, or is this still very much in its infancy?
In terms of IR, very little in IR. There's a lot obviously in radiology. I mean, they have a journal all by itself on AI. I see that there's two ways of using machine learning and AI. One is to basically replace the radiologist. They're trying to segment things. They're trying to give you a diagnosis. And I think that will always struggle because they don't have the clinical side of it. The image doesn't have all of the other data, the conversations that we have with the clinicians about each patient. But where I see it really being used is in selecting patients. And in IR, we have a patient cohort. We don't know what treatments to use. I know that there's a Chinese group that's been working on HCC, looking at using CT imaging to determine what's the survival for if I was to do ablation on this patient. What's the survival if I was to do TACE on this patient, CERT? And so that's where I see its role is in patient selection and helping MDTs come to decisions, because a lot of what we do is based on evidence, but not solid evidence. We don't know what we're supposed to do in certain, and it's always changing. We've got different embolics. So yeah, that's where I've seen it being used, but and where I see its implication in the future.
Thank you. I think we've got time for one last question, and Armin has posted in the chat, what's the best platform to learn when starting with programming and machine learning? Python, R, Matlab?
I think so. I've started learning Python, and a lot of surgeons that I know that have done some machine learning stuff have used R. There's a lot of packages that are already available. I found R a bit clunky, very different to Matlab, but so therefore I've gone on to Python. Basically, Python or R is what I would recommend. Matlab is, I'm only using Matlab because I already know how to use it. So there's a very steep learning curve for that bit, and I might as well use what I've already known. But if I had to start again, I'd probably use Python.
Good, thank you. I think your thoughts are echoed again by Michael, and Greg Macris has joined us. Hi, Greg. He mentioned there are some growing AI-based ecosystem of startups who are focusing on more vascular procedures. So he would be happy to talk about that outside of the session. So I'm going to move on now. So Ganesh, thanks so much again for your time for that brilliant talk, and hope to see you again soon. So our next speaker is Dr. Ed